balancing a couple years ago, and we did ACS on his knee, and he fell into this category of folks that arthritis wasn't significant enough to require surgery, but he couldn't go hiking with his kids, and he couldn't do the activities he wanted to do. And so we did the therapy on him, and he has continued to do wonderfully the past 2 years. He came in, and he's been doing sports, and he's been hiking. He's absolutely delighted, and those kinds of stories are the ones that make you light up, when the folks do well, and they do well for a long period of time, and they can go out without having to load themselves up with anti-inflammatories or other pain medicines, and spend a day hiking.
Our guest today here at the Concierge Medicine Forum and the Docpreneur Leadership broadcast is Dr. Thomas Buchheit, and he is the Director of Regenerative Pain Therapies Program at Duke. So that's a mouthful. So Dr. Buchheit, thank you for joining us.
Thank you, Michael. And I'm going to go ahead and share some slides here as we start, if that's okay.
Absolutely.
And let me know if you are able to see those slides.
Yes, sir.
And go to presentation mode here as well. Okay, how's that?
Perfect.
Great. So thank you for having me. What I'd love to do for the next 20 minutes or so is to give a very broad overview of a topic that is increasingly important and increasingly common throughout our practices. And that is the topic of regenerative medicine for arthritis. I'm going to dig a little bit into some core concepts and some mechanisms, and talk about what these therapies can do, and really, as importantly, talk about what they don't do, and then we'll look a little bit into the future as well. So hopefully this will give a very grounded talk, and it's going to have a little bit of basic science in it as well, but not too much. It'll be a little more clinically oriented. In terms of disclosures, I have several disclosures, but I don't have any conflicts of interest. I do consulting for a few companies, including Sumis, Best Doctors, the North Carolina Medical Board. I've done some consulting for Colon Tissue Gene, which looks at gene vectors for nerve pain, and Mainstay, but I specifically don't do any work or any consulting for any of the companies that make regenerative products. So I wanted to start with just the concept of inflammation and osteoarthritis. And we all know that this is true, and we all know that it probably isn't as robust or overwhelming as it is in rheumatoid arthritis, for instance. But it is present, and it is fairly universally present. Synovitis is universal, and with that, we'll see overexpression of a lot of inflammatory cytokines. TNF-alpha, which we all know well, especially with the treatments of rheumatologic disorders, IL-6, IL-1, and these inflammatory markers do correlate with pain severity in the osteoarthritis patients as well. And there's one other part that's important, which is upregulation of some enzymes and some other aspects in osteoarthritis that might not be as common for everyone, which are things like MMP or matrix metalloproteases. This is some work that we've done, and we've worked with in our lab as well, but it's an important mediator, not just of cartilage degradation, but also of pain associated with arthritis and nerve issues as well. The other part of osteoarthritis is the reduced ability to build tissues. So we have reduced anabolic components to our joints, and very specifically, one of those is TGF beta, transforming growth factor beta, which loses production over time. You know, I'm a 52-year-old lifelong runner, and I can tell you that I probably don't make as much TGF beta in my cartilage cells as I did when I was 25. Some of that is just age-related, and some of it also is activity-related. We can influence this with diet. We can influence this with exercise. We can also influence this with some of the regenerative therapies that we'll talk a bit more about. Before we dig into regenerative therapies, I do want to say a quick word about the current standard of care. And you know, we've all done steroid injections for all kinds of maladies, and I still do common steroid injections for joints. I have tried to get away from the repeated use of high-dose steroids, and I'll explain why in just a minute. I still think there's a role for these. For instance, a patient who has inflammatory change, who's trying to make progress with physical therapy and just can't get over that hump. Those folks, I think, do fairly well with the steroid injection to get them activated, to get them in physical therapy. But I've shied away, and I would caution a little bit from the repeated high-dose steroids, which have shown to be deleterious to cartilage. The other thing that I won't really talk a lot about is hyaluronic acid or viscosupplementation. This is common. It's FDA approved for arthritis. It can help many patients, but the other thing is most of the patients that I see have had this, and the response isn't always overwhelming. So I think the current state of the art is there are things that out there that help, but they're less than overwhelming in terms of non-surgical therapies for arthritis pain. This is the one study I wanted to show. Some of you may be very familiar with this. It was a randomized controlled trial looking at patients with osteoarthritis, and it looked at functional outcomes as well as radiographic outcomes. And what they were able to show was that at the end of the 2-year period, with repeated steroids versus saline, there really was no difference in the groups. These are the treatment groups looking at WOMAC pain and function scores, and you can see that they're really all the same at the end. The part that was important, I think, and the take-home message for us, though, is that the repeated steroid group did have significant cartilage loss on MRI compared with the saline group. And I think the message for those of us who treat musculoskeletal issues and arthritis is that, again, an occasional steroid injection is fine to calm down those inflammatory changes, but repeated high-dose steroids is not healthy for cartilage. So that really gets us into some of the biologic therapies and really a discussion of healing. Many of us have had this ankle sprain before. I've had a couple myself, and you know what it feels like. You get swelling, you may get bleeding. It's painful for a few weeks, but it does heal, and oftentimes it heals quite well, despite a rather significant injury. If you compare that to these less than clinical issues, less than clinical injuries, a repetitive injury, repetitive stress injury, keyboarding, many people have these. They don't have the bruising and bleeding. They don't have this obvious injury. And the problem kind of nags. And so the question is how do you get these issues, these injuries to potentially heal up if they're less than overwhelming? They're not surgery, they're not a sprain, they're not a fracture. And if you look at the healing cascade, it's probably best, and I always think it's best to look at all the regenerative therapies along the spectrum of the healing cascade. So for instance, after an injury, after surgery, what's the first thing that happens? And the first thing that happens are the neutrophils, the PMNs. They come into the area. They do a wonderful job of cleaning up. They do a wonderful job of phagocytizing bacteria, of reducing infection. But they have to go away, and they go away both by dying off on their own and also by being phagocytized by the macrophage. As it turns out, the macrophage is a really important part of this healing cascade because in this process, the macrophage has the ability to turn into really an anti-inflammatory machine. And people call it an M2 macrophage or a pro-resolving macrophage, but this cell has the ability to pump out anti-inflammatory and pro-anabolic substances that resolve inflammation and that really improve healing, whether it is the setting of a joint injury, of surgery, a fracture, or arthritis. It's really an important component, and we'll come back to this as well. There are a lot of growth factors involved. These are all growth factors that are stored in platelets and monocytes or macrophages. I've bolded TGF-beta because it's one of the, I think, more germane ones in the terms of healing and cartilage preservation. But there is a little bit of a growth factor soup that's involved, and you can see here there's many involved, and it's probably a little bit of the combination of all of these, not just one singular one that's important in healing. So if you look again at the spectrum of regenerative therapy options, there are biologically based therapies. And what I mean by that is that if taking I call it biologically based therapy, if you take a substance out of a patient, it's processed, centrifuged, somehow treated, and re-injected. That to me is a biologically based intervention. versus a non-biologically based intervention. These are basically ways to create an injury or ways to induce a healing mechanism without using a biologic. Examples would be microfracturing in orthopedic surgery, tissue or tendon fenestration that I do in clinic. Prolotherapy would also be a non-biologically based regenerative therapy. You're creating an injury, you're creating an inflammatory response to that in the hopes of jump-starting a healing cascade. I'll start with PRP. It has been around the longest. It's had several decades of use. But just to go back a little bit, PRP, it is platelets, but really what you're looking at are really a collection of growth factors that we just showed. It also has variable amounts of neutrophils and monocytes, and I'm going to use monocyte and macrophage interchangeably. Same cell type, different tissue space, essentially. PRP also contains some of these inhibitors of metalloproteases, so these inhibitors of these enzymes that can break down cartilage. There are lots of ways of making PRP. There are lots of devices for this. I'm not going to support one over the other, but if you're interested in doing PRP, I would say look into the kind of substance you're trying to create and then figure out how you can create that substance, because they are different, and you can create a lot of different platelet concentrates depending on what you're looking for. But PRP also has some anabolic properties. It does promote chondrocyte production of TGF-beta, for instance, which is good for cartilage cells. It does increase hyaluronic acid production in arthritis patients, and we know that hyaluronic acid reduces over time, and that's why we supplement that with many folks. And it can even act as a chemoattractant for endogenous stem cells. So it can be very anabolic in nature. It contains TIMPs, which are inhibitors of metalloproteases as well. It is a little bit inflammatory as well, though, and that's been shown just clinically when I do PRP for patients, oftentimes they do have a flare-up afterwards for a few days. And this has been supported by some of the basic science research as well, where you have upregulation of a lot of these inflammatory pathways, especially TNF pathways and NF-kappa B. So mechanisms that increase inflammatory signals. That's probably partly how it works, is that again, it induces kind of a focused inflammation to jumpstart a healing cascade. There have been several meta-analyses out that show it's helpful for 6 to 12 months in patients with mild to moderate arthritis. Meta-analyses from 2014, 15, 17, and 20. So again, pretty clear data that at least for that 6 to 12 month period, it can be effective and is very likely more effective than hyaluronic acid or certainly steroids. I'm going to pass into the realm now of autologous conditioned serum, which is not PRP. A lot of people think it's PRP, but it is different. We'll talk a little bit of some of those differences. And the genesis of ACS, or autologous conditioned serum, was really research that was done in the 90s, again on this role of the monocyte or the macrophage. These cells produce a lot of anti-inflammatory substances, IL-1 receptor antagonists, so a suppressor of IL-1, IL-10. These reduce a lot of these inflammatory mediators. The monocyte macrophage can also increase production of proteoglycan and collagen. And as it turns out, if you incubate whole blood under the proper conditions, you can increase a lot of these anabolic cytokines, IL-4, TGF, IGF, even exosomes. Exosomes are a little bit of a different conversation. It's a cell-cell communication device, and I think a lot of that work is still being worked out. But whole blood incubation does reproduce some of the anabolic cytokine production that we desire. And if you look at arthritis, you could almost think of treating arthritis as a pendulum. You have certain destructive cytokines or enzymes that you're trying to reduce. So for instance, IL-1, TNF, MMP, and certain anabolic ones you're trying to augment. IL-1 RA, for instance, is a very powerful one. And TGF-beta is also, again, a very powerful anabolic growth factor. And really trying to kind of tip the scales of this catabolic anabolic seesaw, for instance, to tip it more toward the anabolic side. Back to the incubation of whole blood. If you incubate whole blood, one of the things that happens is that it does massively increase the amount of IL-1RA in these substances, several hundredfold. And that was really the genesis of ACS as it was evolving and being developed in the 90s. This process has been out for a couple decades now. There was a trial, it was an observational trial of over 100 patients that showed good relief. And actually the thing that I like seeing the most of this is that, yes, it's good relief, but it's also sustained up, at least in this trial, for over 2 years. So getting good longitudinal long-term improvement. And then there was a randomized controlled trial, which is always nice to see. And this was a fairly large one, 376 patients randomized to ACS versus hyaluronic acid or placebo. And as you can see, fairly significant differences in initial response, with ACS being significantly better than hyaluronic acid. And again, the most kind of powerful part of the slide for me, though, isn't the initial separation, but it's the prolonged improvement over time of ACS versus the comparisons. So again, good data from a blinded randomized controlled trial of 2-year improvement after ACS. I'm going to pass on, and again, I know this is a bit of a whirlwind, but we'll cover it, and then we'll kind of summarize at the end some common mechanisms of all this. This is a photo micrograph of some MSCs that we have in lab. Now, I don't actually do the basic science research, but I work with some really smart scientists who do. And this is Dr. Rurongji's hands looking at this. He's growing the MSCs in the lab, and he uses these for a lot of his nerve injury pain experiments. MSCs, or stem cells, are powerful cells. They are multipotent. These are stromal cells that can differentiate into other cell lines, whether that is cartilage, muscle, bone, fat, if you give them the right incubation media to work with. And they're found throughout our bodies. They're found around blood vessels. Matter of fact, actually, many people call them pericytes because they're found surrounding blood vessels throughout. It's a very heterogeneous group, though, and that's been one of the challenges. And matter of fact, we call these MSCs just to globally signify whether or not it's a stem cell, or it's a mesenchymal stem cell, a mesenchymal signaling cell, a medicinal signaling cell. But we use MSC to describe all those. It's a very heterogeneous group, and I'll describe a little bit what I mean by that. They can be autologous or allogeneic. They can be cell cultured, or they can be concentrates. So in the lab, when we make these cells, we will take bone marrow out, and the mesenchymal cells will stick to a plate. We will wash the cells off, and we will use those and culture those over a couple-week period. That's been done in a couple of the studies where cultured MSCs have been used, but again, it takes a couple of weeks to culture up the cells to get enough of them. That is fairly different than, for instance, a bone marrow aspirate concentrate, which is what a lot of people have when they have a stem cell procedure done. That is bone marrow that's been spun down, and yes, they are getting some mesenchymal cells with that, but most of the cells they get, as you can see here, are not stem cells. They're not mesenchymal cells. MSCs represent less than 0.01% of bone marrow cells in general. So they're really getting a collection of cells. But MSCs can also be taken from adipose tissue aspiration, which is a common way to get them. It may be taken from umbilical cord. It can also be taken from placenta. A word of caution, placental cells, I've seen them advertised as stem cells, but most placental products are terminally sterilized. And as you might imagine, in a sterilization process, there's no living cell at the end. So yes, they may be growth factor concentrates, but these are not live stem cells. They've been irradiated, they've been heat treated, they've been denatured in some way, and they're no longer living. One of the questions remain, one of the things that we have researched as well is what are the mechanisms of analgesia with all these therapies, and what are the mechanisms of analgesia with MSCs in particular? And there's another part of this puzzle, which is that MSCs show significant improvement in a lot of the clinical studies, but cartilage growth seems to diverge from the clinical response. And that's interesting because I think the original theory of stem cell therapy is that you implant stem cells into, for instance, a knee, those cells graft on, cover up, and become new cartilage cells where cartilage wasn't before. And with those new cartilage cells now, people have relief of their pain and an improvement in function. And it's really a wonderful model. And it does exist within some, or it has been shown within some surgical settings. So for instance, and with surgical scaffolds and cartilage grafts. But the data doesn't really support that as a mechanism that strongly with currently used MSC therapies. And I'll use this as an example. This was a meta-analysis done in 2018. 8 studies that looked at both functional and symptom improvement as well as MRI improvement. And what they found is, again, patients significantly improved, but there was no new growth of cartilage on MRI. So clear divergence between this good clinical response and the lack of cartilage growth on MRI. So you might ask then, again, what is the mechanism of analgesia here? And this has been clarified some in the past 2 years. There was a study done looking at MSCs given systemically. And with these MSCs, there was really a wonderful induction of this M2 macrophage, this resolving, healing phenotype macrophage. There was increase in IL-10, TGF-beta. There was a decrease in inflammatory cytokines such as TNF-alpha. There were recruitment of endogenous stem cells to the area. The interesting thing is that all the cells that were injected were dead within 24 hours. So MSCs induced this really wonderful healing response, but it wasn't because the MSCs were engrafting onto tissue or living. They were dead, but they induced, it was the immune response to the injection that really provided the pain relief. Dr. G, who I work with and we work with here in lab, also did some of these experiments looking at a mouse model of nerve pain. And he found that MSCs also were tremendously powerful in reducing pain in this animal model, and that he could reverse that analgesia by giving him an antibody to TGF-beta. So not only, again, was it an immune mechanism, but is reversible with an antibody to a growth factor. So growth factor is probably really very important in the mechanism of analgesia here. We summarized a lot of this in a publication we did this past year in the Journal of Clinical Investigations. It was a bit of a group effort with a lot of people. It was a fairly long paper, and it discusses a lot of basic science mechanisms and a lot of clinical mechanisms. And I am the clinician of the group, not the basic scientist. So we work together to put it together. But it does summarize it, and I'm happy to give the reference if anyone wants to copy of this paper.
Yeah, that would be great. I would like to see that.
Absolutely, happy to send it to you. But one of the things we did with this mechanism was look at these common mechanisms, and TGF-beta is clearly one of these common mechanisms of pain relief. And macrophage is clearly one of these mechanisms. Matter of fact, it's absolutely central to ACS. It is the reason why that this product is so rich in IL-1RA and these anti-inflammatory cytokines. It's important for PRP as well, and a lot of the PRP products are very monocyte rich because of this. And it's probably the final common pathway for MSC-based analgesia as well. So just to summarize, and hopefully we'll have some time for questions as well at the end, there are multiple RCTs that support both the use of PRP and ACS at this point for mild to moderate osteoarthritis, not bone on bone, not stage 4, but mild to moderate. There's good 2-year data for ACS, which is a little longer than a lot of the other non-surgical interventions. There's a heterogeneous group for good analgesia after MSC-based therapies, although again, that analgesia is probably unrelated to cartilage restoration and the ways MSCs are currently used in the United States. And there really are common immune mechanisms that really are the foundation of all these therapies. And that to me is the exciting part, because that to me is the part that's going to evolve over time of how do we take these therapies? We know that they work. How do we take them and make them better, make them more consistent? and make them more applicable to a wider audience for hopefully less cost as well. Thank you, and that's most of the slides.
Great. Well, let's keep that slide up. We have had about 10 questions that look like they fall into about 3 or 4 different categories come in here. So I'm going to kind of rattle through some of these. There's more, but I think this pretty much covers it. The first question is, how do the different treatments compare in regards to the standardization of technique and duration of effect?
Yeah, so great question. Standardization of technique is one of the biggest challenges in regenerative therapies right now. You can buy a whole host of different devices to make them. You can customize those devices. You can pull stem cells or MSCs out of bone marrow, blood, tissue, umbilical cord. You can incubate them, you can culture them, you cannot. And the closer we get to a standard technique, the better off we are. And so that's one of the reasons we offer the ACS technique, and I do PRP as well and some of the other therapies in our clinic. But one of the things I do like about autologous conditioned serum is it is a single technique. It is a single standard process. You know, when we set that up, we had the lab director come over from Germany and had us set up a process. So it is a single process as opposed to the rest of them. But as all these evolve, that standardization technique is going to be a really important concept.
Yeah, that kind of piggybacks and half answers the next question. How is the Duke Autologous Cerium different from the other regenerative programs in the US?
Yeah, so it's really kind of a couple things. One is we do offer a spectrum of therapies. So the goal is not to have a single therapy and people either come and get that therapy or not, because everybody's different. Everybody needs, most people need different treatment. So the first thing is it's a full spectrum of treatments. And the other thing is we're actually one of the few sites in the United States to offer autologous conditioned serum. I think there's one other site in California. Maybe and I think that's most of it, but it's one of the few places outside of Germany right now.
And our guest today is Dr. Thomas Buchheit, at Duke. He's the director of Regenerative Pain Therapies Program at Duke. A couple of other questions here for you. This is a pretty basic one. Send us over the link for the papers that you think are relevant that doctors would want to read about and learn more about. And can we have access to part or a couple of different slides through the slide deck? Are those going to be available?
Absolutely. I'll send you the slides afterwards, and you can distribute them to whomever wants to see them. Great. And I'll send you PDFs of the articles as well, or links on PubMed also.
Another one came in. Is it okay to reach out to you directly if I'm a physician or peer and I have a question about this?
Absolutely. This is my personal email here, the thomas.buchheit@duke.edu. And for patients, we generally guide them toward our RPTP email. I get some of those through personal email as well, but we try to funnel those through our professional address, and that's checked daily.
So this is one where I like this one. This question: what are you reading? Whether it's in journals or books, what interests you that helps you stay on top of your game?
Oh, that's a great question. So right now I'm reading about 150 papers for a systematic review we're doing on regenerative therapies. So that is most of my daytime as well as my nighttime reading. But beyond that, actually I'm reading a fair amount on nutrition as well. And that's the part that I would talk to a lot of people about. Nutrition and exercise. You know, we can do these therapies, but part of this also is care of the whole patient. And we actually have done some research in the past looking at omega-3 derivatives, and Dr. G has done some work with that, and those are very beneficial for arthritis and very beneficial for joints. But how does nutrition and exercise and all these components, how do they complement some of the injection therapies as well? Because it really becomes about the whole patient.
This is another question. How do I know if a patient needs surgery versus regenerative therapies?
If somebody is grade 4 arthritis or bone-on-bone arthritis or a full thickness rotator cuff tear, those are surgical issues. And those folks, I send them on to surgeons. You know, the regenerative therapies are for folks who have kind of mild to moderate changes, who may have cartilage erosion or thinning of cartilage, or may have tendon issues that we call, you know, a tendinopathy, but not a full thickness tear. That's really the space for this, is that in-between space. But bone-on-bone arthritis is clearly surgical, and full thickness tendon and ligament tears are clearly surgical.
Another question that came in is, can these therapies be used for spinal disease?
That's a great question. That's a big topic. They have been used in spinal disease. I will say that I personally don't use any of these therapies outside of joints. Now, I do include spine joints. You know, facet joints and sacroiliac joints, for instance, are a joint. There is some interesting data, but I tell patients to be cautious. And actually, I kind of guide them to clinicaltrials.gov if they're looking for a trial. For instance, people ask about intradiscal stem cells as a common question. I encourage them to look at clinicaltrials.gov for registered trials, because if they're part of a trial that's registered, it's probably a fairly high standard and a fairly rigorous methodology and a fairly safe process as well. So I think the spine applications are really still early on.
Well, and back pain is such a big deal and such a big topic for so many patients out there. This is more of a kind of a zoomed out perspective question. A patient comes in and wants to know what the benefits are, what the risks are. Is this safe? Kind of questioning. Maybe the physician isn't an expert in this space by any means. What do I tell the patient or the unfamiliar patient that helps set the expectations correctly?
Yeah, so great question. So um, there's a spectrum of therapies, there's a spectrum of practitioners. If the patient is being taken out to dinner as a consult by a company who is offering stem cells, that can be, I might be careful about that kind of scenario. I would look for someone who has a broad spectrum practice, whether that's within pain medicine, physical medicine, rehab, orthopedics. Is the practice beyond just that single therapy? Because I think that's how people will get the best tailored care. You know, it's like the old adage of everything. You know, if all you have is one hammer, everything does look like a nail, and you really want to have more than one tool. So I'd look at the spectrum of treatments, and looking, hopefully the practitioner or the clinic does more than just stem cells as their therapy, I think, is a start.
Where is a good place to go to find someone extremely capable that is doing this on a regular basis?
Another great question, because it is, you know, you can look at who's doing trials, you can look at who is affiliated with, you know, well-known practices. Larger groups can do very well, but some of the solo practitioners can too. There's not a clearinghouse that I know of. That's a tough question right now. Part of it also may be word of mouth. You know, word of mouth travels quickly, and people's reputations, um, you know, develop over time. And if you're talking with practitioners, talking with patients, is maybe one of the better ways at this point, without an overseeing body of regenerative medicine, which there really isn't right now.
Well, and thank you. That helps out a lot. Another question and I think we kind of answered this, is looking, you know, for someone to take you out to dinner, but it's a little bit, you know, word to the wise, who should not be doing this in their offices. And that's not to single out any particular specialty. I think they're just kind of wondering, if a patient comes in and says, oh, I saw this here, and I saw that this person over here does this, or this clinic over here, what are the correct pathways to lead a patient down the correct way to get correct treatments?
You know, I think just asking questions. I get questions all the time from patients, and we have fairly deep discussions over one therapy versus another. And I think you can tell if a patient comes in and they ask a question and the answer is always the same, I do X for all these indications no matter what, or they're promising to treat 15 different wide variety of diagnoses, all with the same treatment. But I would have it be part of that really important consultation, have the patient ask good questions. And you can usually tell when folks are really deeply knowledgeable. And patients, I think, can pick up on that very quickly as well. Just for instance, for our experiences, that I did a full year of looking into products and everything before we ever started, and the person should have some training. One part of this is the diagnostic part, though, too. Most of us who do this have fairly advanced training for ultrasound diagnostic work. And to me, the ultrasound diagnostic work is really critical because I can see things on ultrasound that you can't see on MRI, because I can do a functional exam on that patient. And so part of the goal for me is to really get a good diagnostic look at what's going on. What do the tendons and ligaments look like? What do the soft tissues around look like? What do the nerves around them look like? And that diagnostic workup, I think, is really important to tailor the therapy. And if you're looking at tailored therapies and concierge therapies, you're looking at really how do you match the treatment to the patient as best you can. I'll use an example. I see patients all the time who come in with knee pain before surgery, after surgery, and it's amazing the numbers of folks that I see that have problems that were just not diagnosed because they chalked it up to arthritis in the joint, and as it turns out, it's a tendinopathy around the joint that frankly wouldn't respond to joint replacement surgery either, because you're not changing the tendons and ligaments around the joint, you're changing the joint space. So I would probably summarize by saying that diagnostic approach, I think, is very important.
Great. And we have two more questions for Dr. Thomas Buchheit. He is the Director of Regenerative Pain Therapies Program at Duke. And so the first one, first of the conclusion of our two questions here is, you lit up a little bit, you smile a little bit reading the bold comments here, and our question piggybacks on that. What are you optimistic about in this particular field for the coming 2021 year? We all have a lot of things in the rearview mirror for 2020, and we're hoping to keep them in the rearview mirror. But what are you optimistic about?
Well, first off, it'd be nice if people could travel again without horrible restrictions from COVID. So that's a global hope. But I think in the regenerative space specifically, the time horizon may be a little bit longer than that. The things I'm very optimistic about is I think that these treatments are going to set the standard for non-surgical arthritis treatment and for tendinopathies in the next decade. And I think we're at the cusp of it. I think the science is going to improve. I think as long as we continue to have science lead the therapies and continue to be conscientious in how we apply these therapies, I think they're going to be wonderful for patients and going to be wonderful for preserving joint health over time, and give people some good options that they've not had before with steroid injections and other things that we've previously had to use. So I'm very optimistic about that. The time course of it is the question mark, though, and I think these will all evolve over time. There's some wonderful therapies out right now, and I think they're going to continue to evolve as we continue to explore some of these common immune mechanisms as well.
And our last question for Dr. Thomas Buchheit. He is the Director of Regenerative Pain Therapies Program at Duke. And you can connect with him at the information located on your screen. We'll have links to the slide decks as well as the information that he shared in the comments section below. But this is more of a personal question, but also a professional question. And if you were to hang up your stethoscope, hang it all up, hang up your spurs, get home, maybe it's a story that you've told your wife, and you're thinking, I think I could literally quit today. And we did it. Like, we set out, we ran the race, we finished, and we accomplished the goals that we set out to. We could close this whole thing and hand over the keys to someone else because this is exactly why we do this. What's one story, I'm sure of many, that comes to mind that just kind of ties it all in and says, this is amazing stuff?
Oh, that's a great question. You know, I saw a patient back I had seen a couple years ago, and we did ACS on his knee, and you know, he fell into this category of folks that arthritis wasn't significant enough to require surgery, but he couldn't go hiking with his kids, and he couldn't do the activities he wanted to do. And so we did the therapy on him, and he has continued to do wonderfully the past 2 years. He came in, and he's been doing sports, and he's been hiking. He's absolutely delighted. And those kinds of stories are the ones that make you light up, when the folks do well, and they do well for a long period of time, and they can go out without having to load themselves up with anti-inflammatories or other pain medicines, and spend a day hiking with the kids. Those are the kind of stories I look for.
Well, that's amazing. And our guest today has been Dr. Thomas Buchheit. He's the director of Regenerative Pain Therapies Program at Duke. Dr. Buchheit, thank you for being with us. As a fellow camper, I am also familiar with that story. So kind of resonates with me. I have 3 kids, and certainly we just got back from camping and hiking this weekend. So, you know, these types of things, it's great to know that there are doctors like yourself that are investigating these therapies and helping patients, you know, live the life that they want to live. Because if it wasn't for doctors like you and others, and these types of programs and these types of therapies, then, you know, the world would be a rougher place and a more rugged place. And thank goodness for you. And we want to thank you for being our guest today. It's been a pleasure.
It's been my pleasure too. Thank you very much.